Awesome. Thank you guys so much for coming out. It's like one of the last few nice weekends, so appreciate you guys sticking it out. What I was going to do was basically give you all the answers that you need to know about when it comes to toxicology. And you guys all know I used to work in toxicology full time, and I remember when I was talking to a colleague, I said to them, you know, most poisoning cases don't die. They do relatively well, but there's really no cure for them. There's very few antidotes out there for the poison patient. So I always tell people, save your money. Most of the time you don't need to call a poison control center because really there's only 6 answers to toxicology. And it's basically summarized in symptomatic supportive care. So most of the time, you know, even if there's an LD50, a lethal dose that kills 50% of animals, it really is symptomatic supportive care. It's literally decontamination, because most of the time there's not an antidote available. It's fluid therapy, cardiovascular support, neurologic support, GI support, and a couple of weird miscellaneous medications like hepatoprotectants or N-acetylcysteine or vitamin K. So what I'm going to do is in the next hour basically give you all the answers you need to know about toxicology. In full financial disclosure, I am an independent contractor for Merck Animal Health, ASPCA Animal Poison Control, Elevate DVM, I blog for Voice, I'm a criticalist at Animal Emergency and Referral Center, and I'm the CEO and founder of VetGirl. All right, so our basic goals of this lecture are basically to say less than 1 to 2 to maybe 10% of the time is there actually an antidote. But there's 1 or 2 drugs I do think are really important for you to have in your clinic. They're not true antidotes, but they're reversal agents that I think are really helpful. So we'll talk about that. We're going to talk about all the answers that you need to know about for when it comes to toxicology. And in case you get food coma, it's really methocarbamol and acepromazine. 2 drugs that are super important in the poison patient, and literally symptomatic supportive care. So we'll talk about a couple of things you need in your clinic. I wanted to really briefly talk about decontamination. I'm not going to focus too much time on it, but when it comes to decontamination, remember, most of the time, the biggest mistake I see veterinarians making is they like to make everything puke, when in actuality, sometimes it's contraindicated. So if you have a patient that is symptomatic, it is way too late to induce emesis. They're already jittery, they're already tachycardic, they're already hypertensive, again, way too late to decontaminate them. So we really only want to decontaminate when they're asymptomatic and when it's recent ingestion. My general rule is if it's been within 1 to 2 hours, it's okay to induce emesis. There's a couple of scenarios where certain poisons like to stay in the gut for a longer period of time, 4 to 6 hours. And those are weird food poisons, grapes and raisins, big wads of xylitol gum, big wads of chocolate, huge amount of like fish oil capsules that all stick or glom together. Anything that's going to bezor, absolutely, you can induce vomiting with those really massive ingestions or those food toxicants. The second part of decontamination I wanted to briefly talk about is when to give activated charcoal. Now, if you guys carry Toxaban, there's both blue top and red top. You want to buy both. One has sorbitol, one doesn't have sorbitol. Most of the time with the first dose of activated charcoal, you want to give it with sorbitol. And that cathartic is basically designed where it makes the patient poop out and defecate out the toxin. This is really important because the way charcoal works is it has to physically bind to the poison. So if the poison is in the jejunum, the charcoal is in the stomach, unless they physically touch, it's not going to work, unless that drug undergoes enterohepatic recirculation. Say that dog hasn't defecated in 24 hours, the poison can actually desorb, so it will unbind from the charcoal. That's why you want the patient to have what they call fecal expulsion. Get them to poop out the charcoal, poop out the toxin bound to it as soon as possible. The dose that's listed on Toxaban is correct, approximately 1 to 5 grams per kg. And I always go on the high dose the first time because usually when the technician is syringing it, half of it is coming out of the mouth. Okay, so go high dose the first time. If you're giving multiple doses of charcoal, I want you to give a slightly lower dose, so 1 to 2 grams per kg every 4 hours or every 6 hours for 4 doses. In cats, you're lucky if you can get a couple, maybe 2 doses in for multiple doses of charcoal. When are we going to give multiple doses? You're only going to really do it in 2 or 3 situations. If it's got these extra letters behind the drug name. So it says Effexor XR. It's an antidepressant that's an extended release product. SR, sustained release. ER, extended release. These are usually little capsules with beads that are enterically coated. Humans swallow those capsules, so it slowly releases a drug. Dogs, cats, they don't swallow it. They chew those little enterically coated beads, and it makes the drug release more quickly, and now they're going to show clinical signs for 24 hours instead of just 12 hours. You're also going to give multiple doses of charcoal when the drug undergoes enterohepatic recirculation. You swallow it, it goes into your gut, goes into your portal circulation, goes back to your bile. With enterohepatic recirculated drugs, absolutely, you can give multiple doses of charcoal for 24 hours. Remember not to torture your technicians when the toxin does not bind to charcoal. And my little shortcut rule is anything that ends with an "all" doesn't bind to charcoal. So things like alcohol, xylitol, heavy metals, they don't bind to charcoal. Okay? Anything that's a liquid or natural element or oily doesn't bind to charcoal either. So again, we only want to give charcoal when it actually binds. I apologize, this is a really long video, so I'm just going to talk through it. But this was actually a marijuana case that we saw on Thursday. This dog came in, the owner said immediately, my dog got into pot butter. And this dog literally walked to the scale and collapsed and became almost obtunded or comatose. Now, I don't know how many of you guys like to gastric lavage. Anyone? Anyone? I love it. I think it's really fun. So I'm basically going to walk you through the procedure of how to gastric lavage. Now this dog was comatose. We do not induce emesis in comatose patients. If this dog was totally awake, walks in, he can protect his airway, absolutely, you can induce emesis. It's way easier, right? In this situation, I only had to give this dog a tiny bit of butorphanol, a tiny bit of diazepam to get this tube in. And I orogastric tube the same way I would if it was a horse. So literally, I'm gonna pre-measure an orogastric tube out to the last rib. I'm gonna apply a piece of white tape by the mouth so I know how far in to insert the tube. I have a little mouth gag, so a 2-inch roll of tape that I put in. I literally feed my orogastric tube directly through that mouth gag. And you want that mouth gag so the dog doesn't wake up and chew your tube and swallow it. And you can see I didn't intubate this dog. I rarely intubate when I gastric lavage. If it makes you feel more comfortable, absolutely go for it because it protects them from aspiration pneumonia. In this situation, as soon as I lightly sedated this dog, I give it an IV dose of meropitant. Extra label, 1 mg per kg, just so he doesn't aspirate when he wakes up. I literally will insert the tube and blow into the tube as I'm inserting it into his esophagus. I feel like it helps dilate the esophagus as I'm sliding this tube down. It helps dilate the lower esophageal sphincter so we can get this directly into the stomach. How do we know if we're in the stomach? Well, if you don't intubate this patient, you have to confirm your orogastric tube is in the right place. I knew pretty quickly that I was in the stomach because as soon as I got into the stomach, I could hear a little bubbling and I could smell hot dogs. So I knew instantly I was in the stomach. But the way I test it is I will literally get my stethoscope, blow into the tube as I'm sculpting over the dog's stomach and listen for more bubbling. I'll palpate the dog's trachea to make sure I can feel one tube, and then I can feel a second tube, which is your orogastric tube. So I'll literally just jiggle. If you feel one tube rattling inside another tube, your orogastric tube is in your trachea. So always make sure you're in the right spot. And then important that you're always prepared before you gastric lavage. So you want 2 buckets, one full of just warm water, one empty one. You want one of these large animal pumps, which makes it really helpful. And you basically want some lubrication to lubricate the tube as you're inserting it. Here you can see I'm actually giving this dog a lot of pumps of water. Remember, your patient's stomach holds the same amount as the shock dose, 60 to 90 mils per kg. So German Shepherd, who's 30 kgs, it can hold several liters of water in its stomach, and that's why you can eat so much in 2 weeks on Thanksgiving Day. You can massively stretch your stomach, okay? We don't want to give too much where it's coming up the esophagus and the aspirate, but you can see I'm lavaging a huge amount, and you normally need to do about 10 to 15 gavage cycles. You'll notice during this video I'm pulling the tube back and forth. Sometimes it's actually sitting in different areas of the stomach. It may be up against the stomach wall. So we actually had someone, and they're not in the video, but actually vigorously agitating the stomach to shake up all that content so it comes up through the tube. So again, we probably did about 10, 15 gavage cycles. We used 2 buckets of water. And again, our goal is to get as much content out of the stomach as we can. The first time I gavaged this dog got into a block of THC butter, marijuana butter. And the first time I gavaged him, you could see oil droplets within it. So hopefully we got some out. We got out chunks of lettuce, turkey, chicken, kibble. So again, you have to do it a lot in order to get it out. And you want to use a pretty large diameter orogastric tube. If you use too narrow of a tube, it oftentimes will get occluded. So when in doubt, be pretty aggressive gastric lavaging. Now, when we gastric lavage and I feel like I've emptied out the stomach, now I want to leave an activated charcoal. This dog would have been too sedate for me to syringe in charcoal. It would have aspirated it. So what I like to do is I like to seed my orogastric tube, and I'll literally just squirt in 60 ml syringes of activated charcoal. So in this situation, what we carry at ARC is we carry UAA gel. So you can see it already comes in these dosing syringes. You can see we're giving 4 syringes or approximately 240 mils of activated charcoal straight through the tube. And unfortunately, by gravity, you have to get the charcoal in the stomach. So we had a visiting extern from Iowa, so I made him come over to blow into the tube. But he wouldn't, so I had to do it. So again, what I normally do is I just wipe off the tube, and literally you'll see me blowing the charcoal directly into the stomach. This is a really easy way of giving activated charcoal versus sitting there and trying to get 240 mils in. But again, really important you make sure your dog doesn't aspirate. The UAA gel, these nice little syringes, just so you know, if you do buy them, the dose listed on them is completely wrong. So I prefer Toxuban. The UAA gel dose is off by 2-fold or 4-fold. You have to quadruple the dose that's listed on there. So literally it's disgusting. You have to cover it right away because sometimes you'll get a little blowback.
Spit out.
Spit out, exactly. And now I'm just going to flush in a little bit of water into the tube. The tech got mad at me. I was like, oh, I'll just use his gastric contents. They're like, no, please use clean water. I was like, well, it just came out of his stomach. It's okay. And yeah, no. I always stay clean during gastric lavage. We cut out the part where I splash the technician with gastric contents. And so the most important thing is when you're pulling out this tube, you have to double or kink the tube, because when you pull out the tube, there's still residual fluid. So we're going to pump a little fluid right in, just 1 or 2 squirts. You don't want to dilute it too much. Get it directly into the stomach, kink the tube, pull it out immediately. One more wipe. And so a lot of people are intimidated to do gastric lavage. It is life-saving, okay? We don't do it a lot, but there's 6 situations where I want you to gastric lavage. So we're gonna kink the tube. And then you'll actually see a little bit of residual fluid come out. So you just wanna pull it out with one quick sweeping motion. And you'll see a little bit drains out. And there, you've just gastric lavaged and given charcoal. So the whole thing literally took 10 minutes, okay? In this situation, we're always gonna gastric lavage with 6 drugs. Calcium channel blockers, beta blockers, deadly drugs. So dog gets into equine dewormer, ivermectin. A horrible muscle relaxant called baclofen. It's a muscle relaxant that a lot of people with MS or severe back pain are on, has a really narrow margin of safety. Anything that approaches an LD50, or really, really bad things like organophosphates or carbamates. In this scenario, this was a really severe marijuana poisoning. In a retrospective study that was done out of Colorado, when they first legalized medicinal marijuana, they had this huge retrospective study, and they basically found a 4-fold increase in marijuana poisoning ever since they decriminalized marijuana. And the 2 fatalities in that study were from pot butter. Pot butter is really, really toxic because it's fat soluble. THC, you boil it, and then after you boil the THC, you put butter into it. It captures the THC. And unfortunately, the owners had thrown the block of THC butter into the garbage, and they had no money. They got declined for care credit. He only had $800 in cash. And in this scenario, it is life-saving to gastric lavage. So we gastric lavaged him. We left that activated charcoal in. We let him wake up a little. I actually tried intravenous lipid emulsion, which I'll talk about a little bit later to see if it helped in this case. And this dog was obtunded, but the LD50 of marijuana is massive. It's 3 grams, it's greater than 3 grams per kg. You can't die from eating marijuana, okay? So you can die from hypoventilating, you can die from aspiration pneumonia, and literally the extern and I were like dragging this dog to his car. The dog was comatose. We put him in the car and we're like, good luck. And I called the owner yesterday and the dog was back to normal. So again, prevent further absorption of the THC, bind it with activated charcoal. You have to work with your owner's financial limitations, and thankfully this dog did great. So again, don't be scared to gastric lavage. It's stressful, but I think it's fun. All right.
How quickly,
yep.
How quickly do you, at what point do you say I'm not doing lavage?
Great question. So the only reason why we truly gastric lavage is if we still feel like there's something in the stomach. So with toxins that stay in the stomach or toxins that can cause clinical signs really acutely, I would gastric lavage within a few hours if they're symptomatic, and if I feel like I might still get a little bit of yield out. Kind of a vague answer, but I'd probably say within a couple of hours. After 4-6 hours, it's out of the stomach. So, what do I want you to have in your toxicology toolbox? These are basically all the answers you need to know about when it comes to toxicology. Again, antidotes and reversal agents, very few poisons have them. Fluid therapy, which you have in your clinic. GI support, which you have in your clinic. Neurologic support, which you should have in your clinic. Cardiovascular support, and a couple of miscellaneous drugs. So, antidotes. First of all, vitamin K1. Everyone buys this bottle, but just so you know, the EPA just mandated 1 or 2 years ago that they get rid of anticoagulant rodenticides. This will take 2 to 3 years before Decon gets off the shelf from Home Depot and Lowe's, but it was mandated as of May of last year. So when you see a mouse and rat poison from now on, you actually rarely will be reaching for that bottle of vitamin K. Okay, it's going to be cholecalciferol that causes horrible kidney failure. It's going to be bromethalin, which causes seizures. Bromethalin sounds like brodifacoum, which is Decon. It sounds like bromadiolone, which is Tomcat, but again, totally different mechanism of action. I always say, I would rather you pay the money to buy a bottle of injectable methocarbamol instead of a bottle of vitamin K. Why? Because vitamin K is absorbed faster orally than injectable. There's a high risk of anaphylaxis when you give it IV. And when in doubt, oral is absorbed faster. Pit bull puppies who are poisoned by Decon, they may be dyspneic, coughing up blood, they'll still eat. So most of the time, I honestly think you'll be using less injectable vitamin K. Fomepizole, which is the antidote for ethylene glycol. They stopped making the veterinary form. You can get it compounded from Roadrunner and a couple other companies. All emergency clinics should always carry it, but unfortunately now it's really expensive. Now it's $1,500 a bottle from the human hospital. So we're resorted back to ethanol. So you can still use grain alcohol to treat your ethylene glycol cases. Atropine. If you see a seizure in cat or dog, please don't give it atropine. We no longer see organophosphates or carbamates anymore. It's really, really rare. The EPA has gotten rid of it. Yes, you can still buy it at Fleet Farm. And it's usually dairy farmers who will buy a Golden Marin or some big bucket of organophosphate, but it's not readily available to the general consumer or the general pet owner anymore. This is the same I don't know if you guys saw the movie The Rock with Nicolas Cage and Sean Connery, where he injects himself with the heart, and that's because of VX gas or sarin gas. So organophosphates have been taken off the market because now they're like hoarding them and using them for chemical warfare. So I always joke, veterinarians will be the only ones alive because we all have atropine. Tupam's also the antidote for organophosphates and carbamates. A human hospital will not sell it to you because they're stockpiling it for chemical warfare. So it's a known antidote, but we can't get it anyway. What about naloxone? I actually believe every vet clinic should have naloxone, even if it's expired. Hold on to it. And the reason why is naloxone will reverse opioids. So if you have a spay that you're spaying at cardiac arrest under CPR, you could do CPR until you're blue in the face. You will not get it back until you reverse it. Okay? So when in doubt, I like to have naloxone for opioid emergencies to reverse it. If you don't have it, when in doubt, just use butorphanol IV. That will partially reverse the opioid. And if something's crashing, 1 cc stat for anything. Okay, you're not going to over-reverse naloxone. So 0.5 ml for cat, 1 ml for big dog. If you watch the old TV show ER, you'll hear them saying 1 cc stat for a heroin addict. So when in doubt, just 1 cc of naloxone. Adipamazole, yohimbine, these are alpha-adrenergic antagonists. Flumazenil, which most clinics don't carry. I don't even think it's worth carrying if you're in general practice. This is a reversal for diazepam or sleep aids, benzodiazepine. So if you're going to carry any of these, naloxone and one of these alpha-adrenergic antagonists are probably the best ones to carry. All right, so let's jump to the 5 important things that I think you should have. The first one, fluid therapy. We all have it. There's a couple of reasons why fluid therapy is so important with the poison patient. One, it helps with renal vasodilation and perfusion. This is super important because a lot of the poisons that we see are nephrotoxicants. Grapes, raisins, NSAID toxicity, antihypertensives, beta blockers. All these drugs, we're trying to vasodilate the renal vessels. We're trying to increase perfusion. The second goal, certain drugs undergo renal elimination. Methylxanthines, amphetamines. So putting them on a high fluid rate makes them urinate out that toxicant. And the third goal is to help replace dehydration. Maybe it's a toxin, they have profuse vomiting, diarrhea, keeps them hydrated. So, my general philosophy, and you guys have heard me lecture before, you know I'm very aggressive with IV fluids. I don't believe in hospitalizing for maintenance. It's not worth the money for the catheter, the $600 overnight. So I honestly typically am very, very aggressive because most poison patients are young, healthy. I don't usually have a heart murmur patients, right? And we see a lot of nephrotoxicants, lilies in a cat, NSAIDs, grapes and raisins, this new type of rodenticide, cholecalciferol. And the prognosis for nephrotoxicants is actually excellent as long as they don't become oliguric, anuric, or as long as it's not an ethylene glycol case. So I don't care what fluid you use, any balanced crystalloid, LRS, Normar, P-Lite, whatever you have. I generally would avoid LRS because it's got lactate in it if it's in liver failure. So say you have a xylitol toxicity, it's in fulminant liver failure, it can't metabolize the L in LRS, the lactated ringers. So ideally avoid LRS if it's a hepatotoxicant. And the only other fluid therapy rule that I have is if it's hypercalcemic, you must use saline. Why? It doesn't matter that there's no calcium within that bag of fluids. The higher the sodium, the higher it exchanges at your sodium calcium receptor in your kidney, the more calciuresis, the more calcium you pee out. So with any hypercalcemic patient, again, you always want to use 0.9% saline. When I'm going to reach for a colloid, something like head starch or vet starch, most of the time I only use it if my patient is becoming edematous or if my total solids or total protein are less than 5. But when in doubt, fluid therapy is life-saving for the poison patient. My ultimate goal, I like to keep them on 2.5 up to 4 times maintenance. Obviously we want to watch for volume overload, but we want to make sure these patients are appropriately hemodilute. My ultimate goal is I want every patient in the hospital vomiting dog, foreign body post-op, uroabdomen, poison patient. I want them all hemodilute to a PCV of 35 and 5. They've done cardiac output studies. Your cardiac output is best when your red blood cells aren't sludgy, okay? I want every patient to be isoscenuric. I always joke, I'm so busy in the clinic, I don't have time to walk the dogs, but I usually try to walk my own dogs in the morning because I want to see what color their urine is. If they're still concentrated yellow, they're still dry while on IV fluids. If it's an ibuprofen case, it's peeing in the cage, it's peeing straight water, it's urinating every hour, you can probably back off the fluids. I also like to make sure every patient, especially an acute renal failure patient, any azotemic patient, always have water in the cage, and I'll point out why next. And I actually will weigh my patients 1 to 4 times a day, especially if they're azotemic. Really easy way for you to make sure that they're appropriately hydrated. This is a cat, a little kitten that was 6 months old that we saw at AARC a year or 2 ago. And the technicians know my biggest pet peeve that makes my head spin is when there's no water in the cage. And so I said to them, I was like, dude, why doesn't this cat have water in its cage? And they're like, oh, he was splashing kitty litter in it. This cat came in with a creatinine of 22. It was only 6 months old. It was about 3.5 kgs. And it was on a pretty high fluid rate, 35 mils an hour. It had been hospitalized for 18 hours. I examined it the next morning. The cat was still bone dry. And so I go to get a bucket of water and look at this cat drink. This cat drinks literally for 55 seconds. And if you looked at his treatment sheet, he was urinating every hour. They're cleaning the litter box every hour. So obviously this cat is massively polyuric. He's like, I'm done. No, wait. Remember, no self-respecting cat drinks water in the hospital. If they do, they're completely dehydrated, right? Because it's their thirst mechanism being triggered. So as soon as you see a hospitalized patient drinking in the hospital, you're usually behind on your fluids. This cat, even though he sounded like he was on an aggressive fluid rate of 35 mils an hour, wasn't on enough. He needed 50 to 60 mils an hour because he was so polyuric. And amazingly, of course, it's a freaking cat. It did fine. It was no longer azotemic and did really well long-term wise. The second thing we want to focus on is GI support. Now, if you've just induced emesis, you want to make sure to give that patient an anti-emetic, right? Because nothing is more heartbreaking than having your techs give them charcoal to have them vomit up the charcoal. So I will literally induce vomiting. I'll give IV meropitant immediately as soon as they're done, and then I start the charcoal within a couple of minutes. So we want to use something potent. So I like meropitant, ondansetron, dilazetron that will counter the emetic. It'll make them hold down their charcoal. It'll help prevent aspiration pneumonia. So really important that we start that right away. You have an easy job. You get to play with puppies and kittens all day. This was actually my friend's clinic in Virginia, and it was a chocolate toxicity. A couple other different antiemetics. Again, I don't care what you use, but use something potent. In my opinion, metoclopramide is too weak. But it's the only one that's a prokinetic too. So if you know your dog has a bunch of charcoal bound to chocolate, sure, add them onto metoclopramide to get them to defecate out that charcoal too. Antacids. I always think that the use of antacids are way overused in veterinary medicine. We always joke if it's got fur, it goes on famotidine, when in actuality, dogs and cats rarely have stress ulcers. But with certain poisons, they can have corrosive injury. Maybe they got into a corrosive. Maybe they got into an NSAID. They got into something caustic. They're azotemic and have a uremic gastritis. Absolutely, use some type of antacid. I don't care what you use. Studies have shown that proton pump inhibitors are the most effective at reducing gastric acid. So you can use oral omeprazole. But remember, you can't give any oral meds if you just gave charcoal. Right? So we use the IV form at AARC, pantoprazole. It's a little bit expensive, so the bottle expires after 24 hours, so I usually dose it every 23 hours, so you can get at least 2 doses out of that bottle. Misoprostol, it only comes as an oral form. It's a prostaglandin analog. I'm not a huge fan of this one because it causes miscarriage in women. So it's also inconvenient to compound for small dogs, but it's probably the textbook best one for NSAID toxicity. I don't care which one you use. You can also use any type of H2 blocker. Most of us have IV famotidine, totally fine. It's the least P450 drug interaction, so it's the safest, but the drug dose of 0.5 mg per kg once a day is too good to be true. Okay? Studies have shown you have to use 1 mg per kg BID for famotidine to be effective. Ranitidine is the only one that's got a little bit of prokinetic. Remember, these are anti-ulcer medications, they're not anti-emetics. Cimetidine, I never use anymore. It has the most P450 drug interaction. The old textbooks used to say you should use it with Tylenol poisoning, so it interferes with liver metabolism. That has been debunked. Doesn't help dogs, detrimental in cats. Okay, so no H2 blockers with Tylenol poisoning. Lastly, sucralfate. I had a GI ulcer during my internship at Angel, and sucralfate tastes terrible. So I actually don't slurry it for pets. I just use the liquid, the Carafate 100 mg per ml liquid instead. It tastes a lot better. Remember, sucralfate only works if you truly have ulcerated area. So if you truly think it's got corrosive injury, it got into ultra bleach, it got into NSAID, sure, go ahead and use it. Just remember, it does affect absorption of tetracyclines and fluoroquinolones. So ideally should be separated by a few hours. Fluid therapy, GI support, and the third thing is neurologic support. The reason why I was encouraging you to buy a bottle of methocarbamol injectable is because the oral form doesn't cut it. The majority of poisons out there cause tremors, so chocolate toxicity, SSRI antidepressants, amphetamines, pyrethrins in cats, compost toxicity, garbage gut, so a ton of different toxicants that can cause tremors. So really important that you have something parenteral that you can administer right away. One situation that I wanted to discuss is some people will actually ask me, can I just crush up methocarbamol and give it rectally? You can, but we don't know how well or how quickly it's absorbed. And if you have a pyrethrin cat that's seizuring, if you want to pill it, a methocarbamol, go for it. But it's going to take way too long to kick in. Okay, so again, really important that you have that injectable bottle of methocarbamol. I also wanted to talk about the importance of sedatives and anxiolytics. A lot of those same poisons cause hypertension and agitation. SSRIs, amphetamines, chocolate toxicity. When in doubt, if you have a hypertensive, agitated, tachycardic patient, the best thing you can give them is vitamin A, acepromazine. Okay, 0.05 up to 0.1 mg per kg, so high dose if needed. Repeat it as necessary. If they're still tachycardic, still agitated, still hypertensive, then after a couple of doses of ACE, I'll actually add on another drug. I'll give them a dose of butorphanol and see if that helps settle them down. There's always a question, but I was told you can't give acepromazine to a seizuring patient. Is that true? That's actually been debunked. Okay, a study came out of Wisconsin a few years ago saying that yes, you can use ACE in seizuring patients. It's veterinary gossip. So if you do have that agitated patient, always assess it first. When in doubt, give it ACE, ACE, more ACE. And if it's still agitated, go ahead and give them that low dose of butorphanol if needed. So this is what a classic amphetamine toxicity looks like. This is what a classic antidepressant looks like. So when in doubt, when you see that hyperactive patient, give it acepromazine. Same thing with cats. When they get into SSRI antidepressants or amphetamines, and yes, they chew into these things, you're going to give them acepromazine. Like I mentioned, buy that bottle of methocarbamol, huge dose range, huge margin of safety, okay, 44 to 220 mg per kg per day. Plum says do not exceed 330 mg per kg per day. You can easily exceed it, okay? It's just based on the amount of propylene glycol in there. It's not a big deal. If you need to, absolutely feel free to use it as necessary. I don't use oral pills rectally. I think the absorption is really poor. If it's the only thing you have, absolutely try it. But I promise if you buy a bottle of injectable methocarbamol, you'll find more reasons to use it. What about if the patient is seizuring? Give whatever you have in your clinic to stop the seizure. So I love phenobarbital. So I'll use 4 mg per kg each time they seizure. You can use diazepam. Remember, we don't normally give diazepam IM because it's got propylene glycol, so it really stings. You can give midazolam instead. Some people will use a Valium CRI. I'm not a huge fan of that because I feel like they've had a barbiturate deficiency. They need more barbiturates. If you have Keppra, you can use that too. So again, whatever you have, stop that seizure. I use propofol CRI very rarely. I've only had 1 or 2 cases where I've needed to use it. So again, throw better anticonvulsants at them first before you reach for an anesthetic. They're probably still having brain seizures on an EEG that you're not controlling with propofol, so they need a true anticonvulsant. The fourth thing I wanted to talk about is cardiovascular support. Everything on the screen is cardiotoxic. So foxglove, the beautiful flower, methylxanthines, diltiazem, caffeine, pimabendin. I've had a couple of cases where owners order pimabendin in the mail. Mailman drops it through the mail slot, dog chews through the whole chewable container, and I've seen dogs with heart rates of 300, 360 from pimabendin, okay? The few fatalities I see are caffeine. It's not from chocolate. There's very little caffeine in chocolate. It's from a dog who gets into a container of no-dose. It kills them, okay? So some of these toxicants are really, really severe cardiotoxicants. Again, SSRI antidepressants, amphetamines, methylxanthines, pimabendin. These are all toxicants that can cause a massive tachycardia. We can also see certain cardiac medications that make patients really bradycardic. Remember, calcium channel blockers like diltiazem are negative inotropes. They slow down the heart rate. They slow down that HCM cat's heart rate, so it's no longer tacking out at 220, so its ventricle has time to relax and fill with blood. Beta blockers. Dog gets into a bunch of propranolol. Remember, betas are going to beta block. Beta 1, your heart. Beta 2, your lung. You have 1 heart, 2 lungs. So with beta blockers, they get massively hypotensive, really bradycardic. So these can cause secondary hypotension. I put ACE inhibitors up here, but my free advice for ACE inhibitors is if you can find a dose in plums, and if it's less than 20 times a therapeutic dose, it's not a big deal. Dog can get into a huge amount of enalapril, huge amount of benazepril. It's not a big deal at all, okay? So typically just look up a dose. If it's greater than 20 times a dose, it's going to be a poisoning issue. Otherwise, if it's less than that, it's not a big deal at all. That said, these 2 cardiac drugs are deadly. There's also a couple of weird antidepressants, Lamictal, or weird anti-arrhythmics that can cause weird arrhythmias in the poisoned patient. Remember, weird plants that have the word dig, these are usually cardiac glycosides, so lily of the valley, foxglove, yew, these are all cardiotoxic. I rarely see small animals get into this. This is more of a large animal. I'm chronically grazing on something. Super, super fatal to large animal. It takes a tiny amount to kill a horse. And honestly, I just don't think dogs and cats chew into cardiac glycosides as much as people think. So, why do we care about the poisoned patient when it comes to the heart? A lot of poisoned patients will come in massively tachycardic. This is actually an ECG from a dog that died from amphetamine. It's got R on T and it cardiac arrested, went into VFib. We care and we do not tolerate a heart rate greater than 180 in a dog or 240 in a cat. Why? This is one of the reasons why we treat shock when they're tachycardic. Because your ventricle is beating so fast it doesn't have time to relax and fill with blood. Okay? It uses up a ton of oxygen when they're that tachycardic. So we don't tolerate that heart rate of 180. Cornell used to actually put temporary pacemakers in German Shepherds, pace them purposely at 180 to get their DCM model. Okay, so it causes myocardial injury, myocardial failure. It can cause long-term DCM. So again, we don't want to tolerate that tachycardia. So, what if you see a poisoned patient that's really tachycardic? First thing we want to do is check a blood pressure. Make sure for some reason it's not hypotensive, of which we would bolus it some fluids. Most of the time they're really hypertensive from agitation. So if they're tachycardic, hypertensive, what are you going to reach for? ACE, right? What if they're still tachycardic and hypertensive? More ACE, and then more ACE, okay? And then you can reach your torvagesic if needed after that. If you have a patient that is still tachycardic after several doses of ACE, it's still tachycardic after a dose of butorphanol, then I'm actually going to reach for beta blocker. You have a really bad chocolate toxicity, its heart rate's still 180, you need to reach for propranolol, okay? Something to slow that heart rate down. Remember the contraindications when we do not use beta blockers. If your patient's already bradycardic, if your patient's already hypotensive, it will make them worse. This is a dog that I treated, a little Pomeranian. The owner ignored the advice when we said, yep, 175 milligram diltiazem will kill your dog. They're like, meh. They gave their own activated charcoal tablet at home, which humans have for colonic cleansing. And then this dog came in with a matching heart rate and matching blood pressure of 43. This dog actually was azotemic in temporary acute kidney failure from not having any blood flow to his kidneys. And so we don't want to tolerate a low heart rate either. If a dog has a heart rate less than 40 to 50, or a cat has a heart rate less than 120, they don't have enough cardiac output to to pump that heart, to deliver that oxygen out to the periphery. They have no forward flow, no cardiac output, no perfusion at all, and that's what causes cell death and secondary multi-organ dysfunction. They go into organ failure from not having any perfusion. So again, they get really hypotensive, they slough their gut, they go into acute kidney injury from it. So when in doubt, if you see a really bradycardic or tachycardic patient, get an ECG on them. This is a dog that had a bunch of runs of ventricular premature contractions. And what you're seeing on the bottom is a direct arterial blood pressure, actually a catheter in the artery. And what you can see here, normal beat, normal beat, normal beat, normal blood pressure of 120. When it has this run of VTAC, you can see it's got pulse deficits. It doesn't have any blood pressure here, here, here. You can see its blood pressure is probably barely 20 to 50. You don't need a fancy direct arterial blood pressure to detect this. You're going to use your two fingers. You feel pulse deficits. You feel like your patient is hypotensive during these episodes. You feel like your patient's perfusion parameters are poor. It needs a drug. Okay, you need to treat it. So we're going to reach for an anti-arrhythmic like lidocaine or procainamide if our patient has signs of poor perfusion. If they have cold peripheral limbs, they have prolonged CRT, they're massively tachycardic, they're hypotensive, absolutely reach for a drug like lidocaine. Remember, lidocaine and procainamide only work for ventricular arrhythmias. So if you have a SVT, chocolate toxicity, his heart rate's 240, you're not sure, lidocaine's not detrimental. It won't do anything if it's a supraventricular tachycardia. So when in doubt, it only works for ventricular arrhythmias. If the lidocaine doesn't work, you can try the same exact dose for procainamide. Some animals will respond well to procainamide over lidocaine. The one slide I should have included is if that patient is really bradycardic, what are we going to reach for? Atropine. So that calcium channel blocker, little Pomeranian that you saw, his heart rate was 40. We actually had to give him multiple doses of atropine. He eventually became resistant to it, and we had to do a temporary pacemaker in that patient. But when in doubt, for ventricular arrhythmias, massively tachycardic, lidocaine procainamide. For that extremely bradycardic poison patient, atropine, atropine, atropine. What about the last few miscellaneous drugs that we want to use? Well, for those of you guys who still have the old appetite stimulant Periactin, don't throw it away, it's great. Cyproheptadine is basically a serotonin antagonist. And the top two poisons that both dogs and cats get into are SSRI antidepressants, selective serotonin reuptake inhibitor antidepressants, and amphetamines. And with these two drugs, their body has too much serotonin. And so you can counter it with this drug, a serotonin antagonist. So, antidepressant patient comes in, they have no money, you've induced vomiting, you've given a dose of charcoal, they can't afford to hospitalize at night, you just say, good luck on your cyproheptadine, and most of those patients will do fine. Okay, so when in doubt, 2 to 4 mg total per cat every couple of hours, approximately 1 mg per kg for a dog every couple of hours for a few days until those signs of serotonin, of too much serotonin resolve. SAMe, life-saving hepatoprotectant. If you have a Tylenol toxicity, acetaminophen, you have a blue-green algae, an unknown mushroom, you don't know if it's amanita, a xylitol toxicity, SAMe is a super, super benign hepatoprotectant that may be beneficial. So I usually will send them home for 1 to 2 weeks of SAMe based on what their liver enzymes are doing. Vitamin K I already talked about before. Again, I rarely use this injectable unless the patient is too dyspneic or is vomiting and can't eat it. I have some people who say, oh, it's a young puppy, it's really small, so I'm going to just give this injectable form orally. We don't do that. I've definitely seen breakthrough when I was at the U. Injectable drugs are not meant to be given orally. When in doubt, just get it compounded or give them a higher dose of oral vitamin K. Make sure to use vitamin K for the correct duration. Remember how I just mentioned earlier that the EPA has gotten rid of anticoagulant rodenticides? I should clarify, they've only gotten rid of second generation anticoagulants. So second generations are the majority of the ones that you see. You'll still see warfarin and Coumadin, which most of the time doesn't work. But with these first generation anticoagulant rodenticides, you only need to give vitamin K for 1 week. With the second generation, the really bad ones, you have to give it for approximately 30 days. So make sure you're giving it for the right duration. The other thing I like to do is I always tell people never give a one-time dose of vitamin K. Why? You have two ways of treating anticoagulant rodenticides. One is the way I treat, because I can't pill my dog twice a day for 30 days. If my dog got into decon, I would induce vomiting, I'd give it a dose of charcoal, and then I wouldn't do anything. I would come back in 2 days, I would recheck a PT at that time, and if my PT is prolonged, then I would treat them with vitamin K for 30 days. If you manage that case and say, hey, Mrs. Smith, come back in 48 hours, I'm going to check a PT. If you give it 1 dose of sub-Q vitamin K, you just screwed up your PT in 2 days. Now your patient is just going to bleed out and die in 7 days instead of 5 days. Okay, so you never give a one-time dose of vitamin K. You either fully commit to vitamin K or you don't give it at all. Your other option is if you don't trust the owner, and a lot of times in the ER, I don't know if these people are going to go back to the referring vet. I don't know if they're ever going to come back. I'll just say, here's 30 days of vitamin K. So that's always another option, okay? But we never give that one-time dose of vitamin K. Any questions so far? All right, the last thing I wanted to talk about is the new antidote, intravenous lipid emulsion. And this is basically what makes your bottle of propofol white. This is what total parental nutrition is. This is what partial parental nutrition is. And now it's the newest antidote for fat-soluble toxicants. So you'll sometimes see it in the veterinary literature is ILE, intravenous lipid emulsion, or IFE, intravenous fat emulsion. It is super dirt cheap. At AERC, we only charge $80 a bag, which means it's probably $20, okay? So you can buy it from Midwest Veterinary Supply or Baxter or one of your accounts. It is relatively inexpensive, and it usually has a shelf life of 2 years. It doesn't need to be refrigerated. You can just throw it in a drawer. But once you open it, you have to treat it just like propofol. So you have to refrigerate it as soon as you open it. You have to throw it away after 24 hours, okay? This was initially discovered in the 1960s as TPN or PPN. It was also discovered for drug delivery, what carries propofol, and now it's an antidote for fat-soluble poisons. So, how does ILE work? I know the screen looks busy, but the basic way that it works is when you give IV fat, it makes your blood lipidemic. And if you actually draw a blood sample, I want my patient to have hyperlipidemia when I check a PCV total solids. When you give and bolus IV fat, it basically creates this lipid sink, this fatty compartment within your blood. And drugs that are fat soluble, like pot, have a wide volume of distribution. As soon as you eat it or smoke it, you get clinical signs right away because it has a wide volume of distribution. It distributes to your tissue really easily. If you have a really bad fat-soluble poisoning, you bolus it IV fat, it literally sucks it out of the tissue, traps it within the lipid sink of the blood, and helps resolve the clinical signs right away. Doesn't always work. There's case reports saying it doesn't work at all. There's case reports saying it's miraculous and it works amazing. So when in doubt, just be aware it is an antidote for certain cases. The doses that we use are extrapolated from human medicine. Using a 20% solution, we give 1.5 mils per kg IV fast over 1 minute, followed by a CRI for about 30 to 60 minutes. If it doesn't work, you can redose it again at that same exact dose. In human medicine, it says do not exceed 8 mils per kg per day. You can easily exceed that with the acute poisoning case, okay? There are a couple of really, really rare side effects from it. It's extra label. It could cause a fat emboli, so patient all of a sudden becomes tachypnic. I have heard of a cat that got it for pyrethrin toxicity, and its corneas became really cloudy from all the lipid, so it was temporarily non-visual from it, and that resolved. So just be aware it's extra label, but it can be used with certain fat toxins out there. So what's a fat-soluble toxin? Ivermectin, certain antidepressants, baclofen, local anesthetics. The more recent ones are marijuana, cholecalciferol toxicity, baclofen, really severe cholecalciferol cases. So when in doubt, you can always call an animal poison control center to see if that drug is fat soluble or not. I do not think it is an end-all cure-all. If you look on VIN, everybody wants to try it, when sometimes it doesn't work or it's contraindicated. If you have a case, like a pyrethrin case, and you give it ILE, it will suck out all your methocarbamol. It will suck out all your phenobarbital. So it will suck out therapeutic drugs. So when in doubt, you always want to try traditional therapy first. In human medicine, you have to cardiac arrest and die before the anesthesiologist will run and go get the ILE. So again, we in veterinary medicine probably jump on it a little bit too quickly, so make sure you try standard therapy first. This is that marijuana case after we gastric lavaged it, where we tried intravenous lipid emulsion. And again, it was $80. It was definitely worth trying, but unfortunately it didn't make this dog spring up. So literally this dog was approximately 40 kgs, so 45 kgs. So we actually tried a slightly higher bolus dose. I gave him 200 mils over 1 to 2 minutes, followed by a CRI, 300 mils for the next hour, and sent him home. I used up that whole 500 ml bag. He did not immediately improve, but some patients, it can definitely shorten their hospitalization. This was baclofen cases that we treated at AERC. And remember, baclofen's that muscle relaxant. So it causes severe salivation, severe bradycardia, severe hypotension. We gave him a bolus of 20% intravenous lipid. And this was him during his IV infusion of ILE. And acutely, he was worse. And that's been clinically reported, because you're all of a sudden changing the pharmacokinetics of the drug. This was 2 hours post-infusion. This is 3 hours. And literally, these patients are usually comatose on a ventilator. So again, you'll see a big variety in whether or not it works. If it works, it's going to work acutely within the first 6 to 12 hours. If it doesn't work, you can repeat it once, but again, don't continue it after 12 hours. It's not going to work. So, in conclusion, when it comes to treating the poison patient, remember, it's really symptomatic supportive care. Get an appropriate history, make sure you've confirmed what the poison is, but literally it's decontamination, antidotes, fluid therapy, GI support, cardiovascular support, neurologic support, and a couple of other random hepatoprotectants or SAMe or drugs like that. Most importantly, don't be scared of doing gastric lavage, can be life-saving, and remember the importance of methocarbamol and acepromazine when treating the poison patient. And with that, I'm happy to answer any questions you guys might have.
What's the free app?
Oh, I actually put a couple of cards out there. There's a free poisoning app from ASPCA. It's got 200 different poisons, totally free, and literally it's got a chocolate calculator in there too, rodenticide calculator in there, so you can calculate different doses, and it's for iPhones and smartphones. Any other questions?
What's this tube to be used for the gastric lavage, and what's it made of?
Great question. What kind of tube do I use for gastric lavage? So Jorvet and Mila both make really nice oral gastric tubes, but they're expensive. They're $100. But their tubes are a little bit unique in that they have one big lumen with a smaller lumen, and when you flush, the flush comes out of the smaller lumen, so you can gavage through the larger one. I don't usually recommend going to like Home Depot and buying a bunch of cheap tubing because that one is really hard. You always want to ideally get a clear tube so you can see through it. So when in doubt, I would just order it directly from an equine veterinary catalog. Those are probably the best nasogastric tubes. Just make sure you have several different sizes for small dogs, for big dogs, and when in doubt, remember dogs eat rocks this big or socks this big. You can use a really big tube. That will lead me to my last point, which I forgot to mention, cats. When it comes to gastric lavaging, we don't gastric lavage cats. The lumen is not big enough for us to get content back. But I'm going to encourage you, if you have a poisoning case, I wish I had a video of this. And cats oftentimes are really hard to syringe charcoal to. They are so easy to tube awake. And literally the last cat that I tubed, the technicians were like, oh my God, can you teach everyone that so we never have to syringe a cat again? Remember, cats are impossible to intubate, right? So the likelihood you're gonna get a 10 French red rubber into their trachea is so rare. So the way I administer charcoal in cats is literally I have a fractious cat that one person's just holding. It's not even sedated. And while one person's holding it, I will literally just put a 1-inch roll of tape in its mouth. And our syringe cases at AERC, for our 3 ml syringes, we just pop out. So it's just a plastic case, syringe case with a hole at the end for the needle. So that's what I use. I'll literally either use a 1-inch roll of tape or I'll use a syringe case. Just stick the syringe case in the middle of the cat's mouth, have someone clamp down the cat's muzzle, feed down a 10 French red rubber. If it's still hissing at you, it's not in the trachea. And then literally get 60 mils of charcoal. I'll first try it with just tap water, 5 mils of tap water to make sure it's not coughing. Literally squeeze in 60 mils of charcoal, pull it out immediately, and you've just tubed a cat activated charcoal. Super easy, doesn't need sedation at all. Dogs, you do have to make sure the tube is in the right place because you can accidentally tube a dog into the trachea. Cats, they laryngospasm so much. It's so easy to tube them charcoal. Any other questions? Ask me today because you're going to have to pay someone in a poison control to answer tomorrow.
What do you use to induce emesis in cats?
Oh, great question. So unfortunately, so the question is, what do I use to induce emesis in cats? Even though there's a dose listed in plums for apomorphine, it doesn't work. So don't bother using apomorphine in cats. We actually just had a paper accepted in DACVECC that'll come out soon of a cat that died from severe hemorrhagic gastritis from getting hydrogen peroxide. ASPCA reports a 25% anecdotal report of cats developing severe hemorrhagic gastritis with hydrogen peroxide. So in dogs, hydrogen peroxide APO, totally fine. In cats, neither of those drugs. Only alpha adrenergic drugs. Xylazine, dexdomitor. Whatever you're having success getting cats to vomit, try that. Unfortunately, I've only had about 50% success using xylazine, and they get super, super sedate from it, so just have the yohimbine ready. Some people have really good success with hydromorphone and midazolam sub-Q, but that takes 30 minutes, and by that point, I feel like you've kind of missed the window. So when in doubt, don't spend too much time trying to get a cat to vomit, just move on to charcoal if needed. I always joke, cats vomit all the time at home. As soon as they eat a poison, their lower esophageal sphincter like massively tightens up.